Hi, my name is Lajla Johansson. I'm a commissioner working for Buckinghamshire, Oxfordshire and Berkshire West ICB. I've been invited to talk about a project I'm working on, a pilot, social prescribers in Tier 4 settings, to talk about how to commission to optimise for delivery. So this particular project is a collaboration between the provider collaborative in our area, CAMS, the voluntary sector, and commissioners within the ICB about how we invested winter funding to test a new model for social prescribing in Tier 4 for children and young people. The pilot is a 20-month pilot with the voluntary sector commissioned to deliver social prescribing model within the inpatient units. The expected outcomes are to have improved experiences for young people whilst they're in Tier 4, improving flow by linking young people back into the community services as part of their discharge plans, hoping that would enable faster discharges, reducing length of stay, and that they will not be readmitted into Tier 4 settings. So that was what we wanted to test with this model. So why this? We chose this really because, as we know, this is still an issue, problems with flow within children and young people's inpatient settings, waiting in the community for Tier 4 beds, and some young people ending up in acute settings for longer than we would wish. Some quite poor patient experiences, particularly waiting in the community, waiting for a Tier 4 bed. We've seen an increase in the number of young people accessing Tier 4 beds and difficulty with discharges, and therefore increasing length of stay. So we felt we really need to do something quite different, because the traditional models that we'd commissioned really weren't able to cope with the demand that was coming through in the picture that we're seeing, and the problem was growing. In addition to that, we also had workforce issues, and are still very much the case, so difficulty in recruiting to staff within inpatient settings, community settings. So we wanted to trial involving the VCC sector, and again do something that was hadn't really been tested before in this environment. The approach that we took was to ask VCCs for proposals for the winter funding, and what we wanted to do was maximise the money that we had available. So this money did come down to place, but I decided that the best way of using the money was really thinking about, well, how does that benefit the ICB as a whole? How does it benefit all our young people, and not just within the NHS? We've been very focused on how we spend money that's for the purpose of NHS. In the new world, we need to start thinking about the money we have available. How does this also benefit our local authorities? How does it help maintain and promote the use of the voluntary sector, so people within the NHS can work to their top of their licence? We used a single tender waiver process, and then put in place a short form NHS standard contract between the ICB and the VCC organisation. And then it was quite a complex arrangement, so we put in place a memorandum of understanding between the ICB, the provider collaborative and the VCC, so we were clear about governance, and if anything went wrong, we had a clear framework that we were working to for how we were going to escalate and deal with any issues. We developed the service specification together. The proposal was originally very high level, but because this hadn't been tested before, we felt it was much better to sit down around the table together and engage the people who were going to deliver it, but also children and young people, in collaboration with them to shape the pilot and therefore develop the specification as we went along. We also did a thing about being really explicit around that the project might end. We may not have the money to continue, and we may find out that actually this sort of model within Tier 4 was not successful. We also established project oversight and governance, and this was actually quite important. We did this in some detail at the beginning when we sat down and discussed the pilot, and this has really enabled us to act very fast in terms of issues as they've come along. Some of the enablers, in no particular order really, and I won't go through them all, but sort of collaborative conversations about outcomes and outputs. So again, I said we developed service specification together and the KPIs. Really felt that in order to try and maximise some innovation, that we needed to test things out a little bit, and I'll come on to some of that in the next slides. We had clear governance discussions, and we're very honest about some of the challenges that we were facing. It is not very easy for the NHS to embrace the ECC sector and deliver it in partnership, because some of the governance arrangements that we have in place with the NHS. So we made sure that in the SOP that we developed, we were really clear about escalation processes and who was responsible for what and what we did when we came up against problems. We also had a sort of no blame culture, which was really important, because when you do something like this, the likelihood is that some things will go wrong, and in fact they did go wrong. But what we were able to do was stay flexible and take early corrective action when we encountered problems. And I think also what you need as a commissioner is to be willing to take some calculated risks, so not risks that would endanger sort of patient safety, but risk around how we commission and how we have different conversations and how we run pilots together. Also work very closely with finance and procurement colleagues, because even though we want to move fast and be innovative, we still have to make sure that we operate within our commissioning frameworks. So that was very important. And we spent quite a bit of time at the beginning making sure we all had the shared vision and engagement, and that has stood us in good stead. Some of the challenge that we found, that this pilot was going to run over 3 different units, that actually the model didn't quite fit all the different units. So we had to change the model sort of fairly early into the pilot. And so we agreed a way forward, and we agreed how we repurpose some of the funding to make sure that we maximise the outcomes and the output still from the pilot. Finding time was quite a challenge, and still is a challenge, because we're all really busy, but actually having a commitment to meet for meetings and making it happen was really important to drive something like this through, because it's quite easy to just be too busy. But if we don't invest the time, then pilots like this tend to not happen and not be so successful. I think some of the things that we came across was actually some of the staff appointments didn't quite work out, and that's what I meant earlier by taking corrective action. So we were quite brave, I think, because that's quite a difficult thing to do when some staff don't work out, but we worked with the particular staff member and in fact enabled them to find other employment that they were themselves much happier with. So it ended up being win-win. But because of the governance structure we put in place, we were quite comfortable having open and honest discussions around what action we needed to take, and providing some support around those actions. And then building in continuity if we weren't successful. And that's always difficult, because often we want things to continue, but that's not always necessary. So that challenge still remains. So measuring outcomes and outputs is really important. So how much did we do? Is anyone better off? How well did we do it? So as you can see on the right hand side, this is some of the sort of data that we use to measure those. And on the next slide here, as you can see, we use some clinical tools to do that, the Warwick Edinburgh Mental Wellbeing Scale, goal-based outcomes, measuring to what degree those were delivered with the young person. We also tried to measure the therapeutic relationship with the social prescriber. And this is a fairly different thing to do within the NHS, but what we do know from research is that a therapeutic relationship is of key importance for success, in particular with young people. We also measured a whole bunch of other things. You can see more sort of softer measures and some hard measures around employment, education and training, so those wider determinants of health. And is the young person able to use safe strategies to manage the physical, emotional health and well-being? So quite a broad range of measures as a sort of basket. And here's some feedback that we've had from some of the young people we started working with. So Grace's story, I'm not going to read it all out. I've had dreams to leave this chapter being unwell behind me. I want to go to university, and I'm anxious as I feel so used to being in a hospital environment, which is a safer and less overwhelming version of the outside world. And we know the young people, and for anybody, research tells us that if you're in a setting like an inpatient unit, you lose confidence really very quickly, even within 2 weeks. And so a bit of feedback from one of her parents. In Grace's case, social prescribing was about building chances for her future outside hospital. And that is really what this pilot is about, and what we're trying to measure and see to what degree can we support that onward journey. So if you do have a spell in inpatient setting, that is not your entire life. Your life goes on, and you have opportunities as you move into adulthood, but need some confidence to take that next step. And then a little bit more feedback. Thank you to one of the units that we worked in. The support helped me turn things around and change my life for the better, which I'll be forever grateful for. I've been clean from self-harm for the longest time since years, and Phoenix gave me a set of strategies that helped and allowed that to happen, which is fantastic feedback. And we're hoping to continue with the pilot for another year, and other feedback we're having from young people and families is very positive, and this is a bit of a sample of it. Thank you much for listening to me, and I hope this has been of some use for you in terms of commissioning to optimise delivery.